So coming up today, not talking organisational structures, but we'll get on to governance stuff. We've got a CCRH update from Carrie. CCTL are going to talk to us about the changes that have been going on in CCTL, where they've come from and where they're to now. And we're also going to do a business and project plan update later on. So just going straight into governance update, keep it fairly short this time. In terms of incidents, there's the usual data that we normally share with you around how we're doing on our incidents and risk incidents, and how many incidents we've had by specialty and the length of those incidents. I think the biggest change in the last quarter has been that we've moved from CUH to Datex. For most of you, that's probably around the recording of your incidents into Datex. I think the thing to mention there, we put it in the update and I'll put it in again this week, is around in the old systems, so in CUH, your location and your specialties were connected. So the minute you picked that the incident happened in radiotherapy, it would automatically pick your specialty as radiotherapy. In Datex, it no longer does this, and you need to pick the specialty separate to the location. So what we're finding is that some incidents are going under the wrong location or the wrong specialty. So for example, hematology, some incidents have been going under hematology lab as location, which is actually in pathology rather than under hematology as in the ward or the day unit or the local area. So just have a quick check at what you're picking when you look at your locations and your specialties in Datex. We've got a little table and I will send it out in the update on Wednesday that shows a little bit more around the different specialties and the different locations that are more common within the Cancer Directorate. But you have to be aware of what your specialty is that you're working in, or the area in which the incident happened, and the location. So that's just a quick one on incidents. There's some data there as usual around our learning. As always, high on our list is things like medication, admission errors. I'm hoping that Mafalda, who is our governance manager, will be back towards the end of the year. We can start to do a bit more around learning from our incidents and closing the loop into what our incidents are and what learnings there are from them and sharing those in more detail. We just need Mafalda back to start doing that more for us. In terms of risks, usual plea around risks. If you think there is a risk in your area, same with incidents. If you've got an incident, please report things. Please talk to your manager about things. We want to, have everything recorded. We should have risks on the risk register. We should have incidents being reported to us. Actually having high number of risk incidents is not a bad thing. It just means we have good reporting. So please, if you think there is a risk in your area that isn't on our risk register, or you don't know if it's on the risk register, talk to your DOM, talk to your specialty leads. They can tell you whether it's there, or they can get it added onto the risk register for you. We do have a number of overdue risks for review. So those of you who are risk owners, please go in and review your risks regularly in the risk register. And the report comes out every month to show you what is due review. So please do go in and have a look at them. Health and safety, again, we are doing health and safety walk around with the quality team at the moment, but Mafalda, when she returns, will pick these up more and be undertaking more. But again, if you think there is a health and safety risk in your area that applies to your staff, please, or to you, please do talk to your managers about it so that they can get those added onto the system. These are the risks we have on the risk register for health and safety. So again, there aren't very many and there are only a few areas, but if you think there is a risk in your area that is a health and safety risk and it should be on the risk register, please highlight it and we can look at getting those added. Your safety is important to us and your work environment should be safe. So any issues with that, we should be highlighting. Documents and policies, I will just highlight CCTL, who I remember Sarah highlighted to me last time we did this, and number of documents overdue review were well over 100, and it is now down to the 90 mark. So well done CCTL for getting those under review and getting them done. She said we'd see that come down dramatically, and we have. So just a reminder of documents and going through what is now the document management system. So we've moved away from calling it CUPulse. For those who use it in onc and heme and radiotherapy, we now call it the document management system. Just a reminder to get your documents reviewed when they are due. If you think you're using a document and something has changed, please talk to the authors and see if you can get that updated. We have a number of Merlin documents, and specialty teams will know where these are that are overdue review from Merlin. Some of them go back over a year. There is a large push from a trust perspective now to get those published and updated or removed if they're not any longer required. So just a plea to those specialty teams, or if you're involved in any of those, to help get those through the system. As you can see, some of them go out to 2021, so we shouldn't have documents that old in the system still that haven't been reviewed. A bit of a busy screen that, but you'll be able to see that when we've recorded it, and you can watch it back if you wish to capture it around who's got documents and where they're overdue review and how far back they go. And then, as always, the patient experience. So just some snapshots of some feedback here from our patients on what's great about our services. And we spend a lot of time nagging you to do stuff and a lot of time looking at things that aren't right and patient complaints that come through, but we just want to celebrate sometimes that actually we have really good services and really good people. And these are some of the positive, lovely comments we get back from our patients and our carers and visitors about the services that we provide, you will provide. So just to note that and to say thank you for what you do away from the busyness, the nagging and everything else that goes with it. These go out to, there's a big list that goes out to all the specialty team leads, so they should have them for your areas, all the good and the not good, but all the good comments there. So hopefully they're sharing them with you in your areas, but these are a snapshot for you there. I don't know if Claire's appeared. I can't see her on the screen, but I can't see everything on the screen.
I have, I'm here.
She has. Well, anyway, you've got a bit of time, Claire. That's all right. Carrie's there. I can see her though. So I'll get Carrie to do us a CCRH update.
Great. Thank you very much. Good morning, everybody. Few updates for me, not particularly long today. Kevin, can you move it on? Please, thank you. So first, I thought I'd just update a little bit about the progress on the physical build, and most of you will know that Car Park 3 has been closed for some time now, so that so Lang O'Rourke could undertake some initial survey work, which they have now completed. So there's actually not much going on at Car Park 3 at the moment, but towards the autumn we will expect to see the hoardings go up. So that's the boarding that goes around the edge of the site, where we are doing some work around what those hoardings will say and what they will look like. And then the archaeological work will start this side of Christmas, we hope. So more digging underway. In the meantime, we continue to work with our design team and with Lang O'Rourke on what is called the REBA4, so stage 4 design. This is very technical building design, building on the really the baseline design that we did in 2022 and a little bit in 2023. So we are being inundated at the moment with questions about things, so thank you very much for all of you who have helped us reply to questions. We've covered a lot around wayfinding recently, power requirements, talking about cold store specifications, blinds, access and security. So lots of different details which we're having to give information back to Lang on. Excitingly, the arts team have made progress with the 2 major arts commissions for the building, one of which will be part of the entranceway, and the other one which is about the vertical walls which go up the alongside the lift wall, actually, on the internal side of the building. So they have selected one artist now for the ground floor, and are close to doing so for the second piece. So hopefully we'll be able to see some of those designs soon, because that really is bringing the building to life. So really exciting. Lots of patients, as well as some staff involved in those discussions. In terms of the overall programme for the hospital, we are still working on a 2029 opening date, but the programme remains under quite a lot of discussion, both with Lang and with the new hospital programme. So we're hoping that we will see some result of that in maybe the next couple of months, but that has been ongoing for some time and is now subject to a lot of very high level discussions as we negotiate that and the price with Lang O'Rourke. So lots going on. Thank you very much. And then just outside the direct physical build, I've just listed here some of the other work that we are involved in. Ingrid, who's on the call, has been leading along with our Trust Digital team a review of the digital requirements, and we've also got an external consultant, Health Innovation Consortium, involved in that piece of work, who are working across cancer and children's. So some of you will have been involved in those discussions, and that's still got quite a lot of work to do there. Elaine's kicked off a piece around medical workforce, and again, we know some teams have been involved in that. Just at the start of that piece of work at the moment. Highlighted about the organisational development plan. We've got a big piece of work to start around how do we think this building will feel differently? How are we going to work in this building which is different to what we do now? One of the patients said, how are we going to work with the university so that we are family and not just neighbours? And I like that analogy. So what we really need to make sure that we make the most of our co-location with the University of Cambridge in this building, which will require us to do something in advance of moving in. We're trying to prepare for the Cancer Summit, which is a regional event in September, where we are involved along with other colleagues. Lots of equipment planning going on to review our requirements and the costings. We've had a run of presentations to the CCRH governance structure, the operational delivery board. So this involves Claire Stoneham from an exec perspective on what we think our outpatient day unit inpatient models will look like, and that's just feeding back to the work that we've been doing in our working groups with many of you. And Ingrid and Rachel continue to be very involved in some of the work which you guys are doing already around day unit and outpatients in particular. So lots going on, lots still to do. Thank you for the opportunity to update. I'm sure I'll be back next time.
Thank you, Carrie, much appreciated. Still lots going on, isn't there? Which is fantastic to see. Thank you very much. And again, if anyone's got any questions or anything, please pop them in the chat, or you know where Carrie is, you can contact her directly. Now, the next team that we've got to present, I am incredibly proud of. The team has come a long way, and if I'm very honest, I wasn't sure if they would still be here as a team or not as part of our directorate this time last year. So I'm very, very pleased that they are still here and that they've got a wonderful story to tell us, I hope. Good morning, Sarah, welcome.
Thank you, Claire. That was a lovely introduction. Thank you. And I too am incredibly proud of the team, because we really, really have come a long way from a place that I also didn't think we were going to recover from. So we've still got a lot more work to do, but we're definitely on the right trajectory now. So I think in this short summary I'm going to give now, I think my aim is to just sort of describe the journey that we've been through, but also to hopefully inspire those other teams who are facing difficulties that are quite common in the NHS. But you know, you can come out the other side. Right, next slide, please. So for those of you who don't know, CCTL, we were formerly the Stem Cell Lab. We sit in hemato-oncology within the Cancer Directorate. We are a therapeutic laboratory, so we're very separate from pathology in the way we operate. The bulk of our workload is supporting the East of England Regional Bone Marrow Transplant Programme, and that covers Cambridge, the Norfolk and Norwich and the East of England Trusts and Ipswich as well. We're responsible for the procurement, testing, processing, storage and the issue of human stem cells for transplant. And we handle approximately 130 patients a year, and this is ever increasing. We are integral into the Commission CAR T service for the Trust. This started in 2020 and has also continued to increase in numbers and diversity, which is great. And we're also integral into the facilitation of cell therapy trials across the Trust as well, where we operate as a regulated cell handler. And this basically means that we're responsible for the procurement of any starting materials from our patients, including apheresis and tumour. We store the advanced therapy medicinal products in liquid nitrogen. We can prep them for administration, and then we can issue them to the patients under the pharmacy service. Next slide, please. So the then of CCTL, I'm only going back a few years because that's where most of the dramas happened. So in 2022, our workload was way in excess of our capacity for our staff resource. Our workforce suffered a significant amount of stress and anxiety related illness. This led to an unprecedented level of staff resignation, and unfortunately also culminated in a multiple serious incidents due to delayed patient treatment. And essentially, towards the end of 2022, the department was officially declared in crisis. It sounds very dramatic, but that's a sort of a sign of how bad things were. The options that the head of program and head of operations faced was essentially option A, to pause the service to enable it to recover. But the second option was to close the service completely and outsource all of the work to do with the program, which potentially may have been a safer option, potentially, but we potentially also would have risked losing the service completely and not being able to regain it back. So next slide, please. The decision was made to pause the service, and Claire worked phenomenally hard to put together an emergency investment case to temporarily outsource the processing element of our service to a third-party organisation called BioVault down on the South Coast. The emergency investment case was primarily to fund this outsourcing at heinous cost, but also to address the critical gaps in the CCTL workforce infrastructure to enable the department to recover and also develop the workforce that we'd lost so suddenly. And in addition, to fuel this recovery plan and start building for the future. So when I came back from maternity leave in September 2023, I was presented with a very, very, very broken department, but also the resources that I needed critically to start that recovery. And I started that together with a new member of staff, Dan Gleghorn, who can't join us today, who started in post using funds for this from this investment case as Associate Operations Manager to really get this recovery plan written down, put with KPIs to a time frame and to commence it. Next slide, please. In 2024, so as I wrote this presentation now, in 11 months, we have made more progress to this than I could ever imagine. And the areas of the most success have been in the workforce, the repatriation of the processing element of the service from BioVault, and in many, many other ways, how the department has developed. So these are the areas I will just summarize what we've managed to achieve. Next slide, please. So firstly, looking at the workforce. So the key figure here is that in 2023, oops, is it gone?
It was that shocking it's vanished.
It's that shocking it's vanished.
What
I've got
clicked,
nothing,
Kevin?
Sarah. I haven't clicked anything.
Oh,
trying to open a beer. There you go.
There we go.
Oh, I don't know. Okay, so the key figure here is that into June 2023, so shy on 12 months ago, we had a 42% vacancy rate. And we were very, very, very limited for the workforce in bands 5 and 3, which are absolutely critical for the processing arm of the service. So next slide, please. Using the money from the investment case, we have worked exceptionally hard on recruitment, and there's been a staggering improvement of now a vacancy rate of 3.7%, and this has been stable now for the last 3 to 4 months. So we are, bar one post, I believe, at full establishment. And we have reasons for that one vacancy, and that's because we were being quite strategic with employment and trying to fit in posts around training schedules and things like that. So this is a massive success in itself. Next slide, please. The next couple of slides are about staff sickness. So as I alluded to, 22-23, we had really high staff sickness. And you can see here the summary review from 2023 is that a total of 1,800 hours were lost across the workforce to sickness, with a staggering 1,000 of these hours being directly associated with anxiety, stress, and depression. And when you see figures like this, it is almost no wonder why the staff turnover was so high. So next slide, please. So with the investment case and the recruitment and change in management, etc., we can see that this sickness rate has come down. It's worth noting that although the 928 total hours does seem still quite a lot, our workforce has effectively doubled. So by that estimate, we can estimate that sickness has actually halved. But more importantly, we only have 9 hours in the anxiety, stress, and depression category, which I believe attributed to one member of staff on one occasion in June of 2024. The sickness has remained stable across 2024, apart from one peak that we had in April, and that was related to, again, one member of staff, with the reasoning being other musculoskeletal and was not in any way directly attributed to work. The other sickness that's been experienced largely falls into the cough, cold, and viral infections category, which we know is very, very normal and standard in a workforce with seasonal fluctuation. So again, I think this is a huge increase, a huge improvement. Okay, next slide, please. I managed to do all of that without my little green circle reminders. They were there. They were there to help me. Okay, so the next slides are quite data heavy, so I'll kind of try and summarize for you. This slide is basically depicting the numbers of products we sent to BioVault to be processed over the course of 2023 and 2024. We can see that there's a sort of an increase in that outsourcing, a plateau, and then it's gradually declining across all of the tissue types. The increase, should I note, in July 2024, where there's 9 outsourced as opposed to 7 in June, shouldn't be perceived as negative, because actually the data shows that our workload as a whole was much, much, much higher in July compared to June. So we did still process a lot in-house. So you know, that's why we're not seeing that decline on that top graph. And the bottom graph shows the number of harvests that were actually cryopreserved in-house at CCTL versus BioVault. And again, you can see some fluctuations, but it's important to note that towards the more current time is that we are now processing a lot more in-house, which shows that we are progressing nicely with the repatriation plan that is due to finish in September. Next slide, please. So this is a bit more information on the repatriation. Again, lots and lots of data, but basically this is just showing the split across our different tissue types but that we handle. In summary, the preservation between CUH and BioVault in terms of autologous cryopreservations has been pretty stable. The DLIs are also quite sporadic, but the Norfolk and Norwich is normally almost processed in-house, and that was all in 2023. But then moving on to 2024, next slide please, where we are now, you can see that there's a lot more green on the graph. So across all of our products, you can see that we're processing more and more in-house. Specifically, all of our DLIs are now cryopreserved in-house, which is amazing. This enables the fresh doses to be given to a patients, which are shown to be of great clinical benefit. So this is all on track, and the aim is that by mid to end September, everything will be green and everything will be processed in-house, and none in BioVault at all, which is absolutely brilliant. Next slide, please. This next slide just depicts some of the extra things that we've managed to achieve really in the past 11 months alongside the repatriation. So these things weren't denoted in the recovery plan per se, but they are all areas that have had a lot of focus to improve patient care, supporting our staff and building for the future. So to name a few examples, in the improving patient care strategy, we've managed to execute nearly all of our CAPAs for both HTA and JC inspections, which means we are well on track for becoming reaccredited with JC, but also retaining our Human Tissue Act license as well. We've started on a number of really exciting projects to bring specialist processing in-house. Despite the horrible graph that Kevin keeps presenting every month about our QMS and QPulse, we are making enormous progress in bringing our documents under control and executing CAPAs and change requests. Dan has done some amazing work in putting a lot of our data and operational statistics onto a dashboard program, Power BI, which is proving really useful in providing us with data about how CCTL is actually operating, so we can find out gaps, make improvements, but also praise the staff where praise is due. In terms of staffing, we now have a very clearly defined departmental hierarchy and infrastructure, and this was always going to be important, but particularly important with a new team that's doubled in size. We have increased the amount of CPD that the staff have available. We've got very structured team meetings across the different levels of the hierarchy. We've got departmental officers that are named now. We've got a very heavy focus on training and competency. And that the proof is in the pudding there, in that we've managed to repatriate, because it shows that we're training our staff in a way that we can actually bring processing back in-house. We have a monthly staff bulletin, we've had a staff social, and we've got ongoing educational talks every 2 weeks as well. And in general, I think I can say that the team are very happy. We have a lot of engagement with them now. There's open door policies where we can see we can have feedback from staff and act on that feedback. And then in terms of building for the future, we are working very hard to get a piece of software called STEMsoft online, which will enable us to move slightly more away from a paper-based system. And we've also worked very hard on building the investment case that will hopefully enable us to move to JCBC, which are new state-of-the-art labs on campus. But I've also had the time to put together a departmental strategy for CCTL, which aligns with the trust-wide visions for cell and gene therapy. And without the investment case for the recovery plan, I wouldn't have been able to do that. So we've really come on in leaps and bounds. Next slide, please. So in a very quick summary, you've probably all seen the trust triangle strategy, and all I've done is develop a local vision for CCTL, which incorporates these strategy areas as well as the trust values. And what I've also done is define a number of objectives together with action points and effectiveness measures that are now documented, and their progress will be tracked regularly to make sure the trajectory of CCTL stays on track. Next slide, please. And that was it. Just huge thanks to Claire and Charles for keeping the department together and hanging on by a thread whilst I came back from mat leave, and then to Dan, who again has only been employed 11 months, but has worked absolutely tirelessly with me to get CCTL back on track, and who also put together a number of the slides for me, and also to the CCTL team, because, well, they're the most important people. Thank you.
Thank you, Sarah. I don't like to remember the day, but I will remember it once where I think it was me and Libby Cook as our head of workforce and one member from your team, and that was all we had one day. And my skills for processing cells ready for a bone marrow transplant are limited, and Google didn't do qualifications within an hour. So that's how bad it got one day. And I think I'll just extend your thank you, if I may, to Claire Cowling and the BMT nurses. I know we've caused them a huge amount of extra workload in the last year, and without them chipping in alongside the apheresis team as well, I think it's definitely been a team effort. For everyone else on the call, I guess this could have meant, and the conversation we had was that we would stop being a bone marrow transplant centre. So ultimately that was about 200 patients who currently have a life-saving transplant with us would not be able to have it and would have to travel to either London, Birmingham, further afield. So it would have been a huge disaster if we didn't keep this going. But a brilliant success, and please, if any of you are struggling within your teams with sort of team morale and things are really, really tough, you can absolutely get through it. I say never thought CCTL would still be here a year later. So brilliant job. Thank you very much.
Thank you.
What have we got next? Oh, it's me. Oh, I'm going to. I'll try and keep this light and upbeat. So just thought we'd do a review of our business plan. Those of you that have been on these calls before will know that every year we have to produce something, normally sort of October, November time, that says what we are going to achieve as a directorate for the following financial year. So our 24-25 business plan that was approved back in March, and this is just an update on where we are against that plan. So next slide, please, Kevin. So sorry, this is a bit of a squeezed page because, as always, in the Cancer Directorate, we like to commit to doing lots of things. So in this year, these are the really, really high level things that we'd agreed to do. And then I've tried to sort of rag rate along the right hand side with the coloured blobs where we are along with them. Some are further along than others. We have started everything on this list, and you'll see a couple of things in green we've already managed to achieve. There's a really common theme that flows through all of these, and that is around efficiency, doing more with less, really thinking about all of that money that comes out of all of our salaries every month that pays for tax, that goes to pay all of our wages ultimately, and are we spending it in the most efficient way? Are we getting most value out of the money that we spend on our NHS services? Can we reduce the amount of time people spend in an inpatient bed? Can we see some more patients in clinic? All those sorts of things are really important. And then there's also a theme running through this as well around reducing our backlogs. So as we all know, we've still got lots of patients who have waited a very long time for treatment, particularly in our non-cancer services. And it's really important that those patients are seen much quicker. So we've got to try, and that's all about efficiency. If we can do a little bit more, even if it's just that one extra patient in an outpatient clinic, it all helps. So this is where we are with all of those high level plans, and you'll see, as Sarah's just mentioned there, the expansion of our cell therapy lab to the JCBC facility is on that list. So I look forward to a positive outcome of investment committee in August for that one. Next slide, Kevin, please. So one thing we've been asked to do recently is to look at where we've had business cases approved and we've had additional investments. Are we delivering on what we said we were going to deliver on? So we've had loads of money, we've recruited to posts, fantastic. Are we doing what we said we were going to do? So there's a list there, a very high level list of all of our business cases that we've had approved in the last year. Now, that's not to say that those business cases need to stop. It's not to say that anything needs to change. And actually, we've had some amazing successes in these business cases. I'll pick one off that list. We did a review of our one-stop kidney cancer pathway that we had a business case approved last year. We reviewed it recently, and I'm hoping that the team will bring it here to show you all. We have, with the evidence that we've got so far, we think we've saved about 4 weeks in terms of a diagnostic pathway. So if you're suspicious of having kidney cancer, we can reduce the time it takes to tell you that news by 4 weeks, which is a huge amount of time. So some of these have done brilliant things. We just want to check that we have done what we've said we were going to do. We've spent our money in the right way, and that we're getting the outcomes out of them that we were. And again, it'd be really lovely to bring back some of these success stories to tell you all about. The little graph on the left-hand side there is showing our pay rate. So you probably don't need to see the detail of it, but you can see that overall that pay rate is going up as the weeks go by. We're recruiting to lots of our vacant posts, which again is fantastic, but therefore we are spending more money. And if we're spending more money, in theory, we should be able to see more patients, treat more patients with all that money that we're spending. And again, that's got to be the real focus now, that we are using that funding appropriately. You want to lead on to the next slide then, Kevin? Thank you. So sorry, more graphs. So as I said before, this is about spending what we've got and using it well. So the graph on the left-hand side is all of our elective activity. So that's day admissions, ward admissions, theatre cases, anything that's an elective. The blue line is what we said we were going to do this year in our plan. And the pink line is what we've actually done. So you can see at the start of the year, we were doing really well. Our pink line was well above the blue line. We were doing lots more surgical cases, elective cases. Our day units were all really busy. You can see as we've hit sort of June, July time, that pink line is now below where we said we were going to be. So we've really got to look at, are we maximising all of our spaces that we've got from an elective perspective, and really get that line back up again. And again, that goes back to, is every single chair in our day unit filled all the time? Can we squeeze that extra patient in? Are all of our theatre lists booked? And we've been doing some work recently on theatre lists to make sure that we are booking every single minute in theatre. We've been adding extra cases to make sure that, again, we're getting those patients treated that need treating. But if we've got a surgeon and a theatre team standing there, we want to keep them busy. So really important to do that. On the right-hand side there, we've got our outpatient attendances. So this is obviously all of our outpatient clinics. Radiotherapy gets counted as an outpatient treatment, and this is across, again, the whole directorate. So you can see again at the start of the year, really great. Pink line was above the blue line. We were doing fantastically, but we've just slightly dropped again in June and July time there, that we're not quite seeing as many patients in outpatients as we said we would. Now the blue line you can see has got some forecast drops in it. So there's a big drop coming, which is towards the end of August. Obviously, lots of people take leave in August. It tends to be a month where we don't do as much activity as we would normally do. The other drop that then comes is Christmas, which again, with bank holidays, we often do less work than we would normally do. So we've really got to try and maximise now as much as we can, and say just that extra patient in clinic. So those of you that work in outpatients, just really check that every single clinic slot is filled with a patient. every day unit slot is filled, all our theatre lists are filled, and that will mean that not only the patient's getting treatment, which is the main thing, but that we are bringing as much income in and paying for all those extra posts that we've all recruited to. Next slide, please, Kevin. So I just wanted to take a moment after a slightly heavy going data to say, actually, we're doing really good. I got asked last week whether the sharks were circling and whether things are going bad. And actually, I thought this is a really good opportunity to recognise that against the national requirements, we are doing really good. So particularly for our benign teams, so for haematology and urology who have benign patients, the national requirement was that patients should not wait longer than 78 weeks for treatment by April 24. Now, you'll all agree 78 weeks is far too long to be waiting for treatment. That has come down from 104 weeks, so 2 years, and we are slowly bringing that wait time down. So urology and haematology have hit that mark by April. Our next step to achieve is that patients should not wait longer than 65 weeks for treatment by the end of September. And what we're actually forecasting is that we will be at that point by the end of August, which is an amazing achievement to get there a month early. And a huge thank you and well done to urology in particular, who've had a big long list of patients to get through for this, but to all our benign teams. We've said that 70% of patients on a suspected cancer pathway should start treatment in 62 days, and that's by March 25. We've actually achieved that since October 23. So again, we're well ahead of that, which is fantastic. The national target still remains 85%, but nationally we're trying to just even get back near that mark is a big challenge for lots of other hospitals. We've got hospitals in the east of England who are at 30%, 40%, so we are doing amazingly well. And then the last requirement there is around 77% of patients who are referred as an urgent suspected cancer, so the old 2-week wait, as some of you all know, should receive a diagnosis by day 28, and that's again by March 25. We've been in the 80+% again since early last year. So again, way ahead of target, which is fantastic. And the most important thing there is not the targets. It's that as a patient, if you were referred on these pathways, you would get that diagnosis treatment quickly. And for those patients who have been waiting a long time, that wait time is coming down. So again, a huge thank you to you all. I know it is incredibly tough and it is relentless, the requests that come week after week. But all you can do if you're working in a clinical service is make sure those clinics are full, those theatre lists are full, those day unit treatments are full, and that will mean that we achieve on these targets as well. Next one, Kevin, please. That's me then done on that. Has anybody got any questions? I'd got a couple of points, I think, on a next slide that I just wanted to remind people of. We do those now if anyone's got any questions. Just wanted to make a note for Attend Anywhere. Hopefully you've all seen it in the daily briefings that today is the last day that Attend Anywhere is working. They convert from tomorrow to a new trust. Ultimately it's through Teams. I think in the CUH bulletin today there was the links that are there as well for all of the clinician guides, the admin guides. If you are administrators within your clinical teams, please make sure that your clinicians are aware of this change. They will no longer be able to log on tomorrow to their clinics as normal using Attend Anywhere. If patients and clinicians don't manage to work this tomorrow, we don't want patients being recorded as a DNA and not being offered other appointments. We're going to have to be flexible for a little bit just to make sure that patients really know where they've got to access and equally our clinicians know. So please make sure your teams are aware of that. And a little reminder around appraisals. It is appraisal season. Those of you that haven't quite managed to have your appraisal done yet, please make sure it's scheduled in. Talk to your line manager if you don't have a date yet for your appraisal. It's all been recorded on DOT, and there is loads of training and support available on DOT if you're not quite sure what to do. The DOT process for recording your appraisal, if you're a manager, is a little tricky, takes some clicking and getting used to. The objectives are slightly separate to the normal appraisal, so please persevere with it. And if you get stuck, your line manager will be able to help you. But please make sure they're all done by the end of September. They were my updates. Has anyone else got any questions for me?
I was just going to say IT requests. Please, if you've got any IT requests, we have got the portal to put those requests into. We have to have Directorate and divisional approval before we do them, before they go onto the Trust IT portal. So please do put them through the local one. It's in the weekly update and it's on our Connect pages. And I know there is a back list of laptops that have been requested, and that list goes back to April 23. I still have it. I still have those on there. I'm still chasing division. I'm still pushing for answers, and I will continue to do so. But if you think you've requested something and you want to check, email the Cancer Directorate senior team inbox and we'll pick that up. And then just the other thing was the Connect pages. We've continued to build our Cancer Directorate Connect pages, and there's a really useful page on there now about our policies and processes. So if you've got anything you want to query, it's a good place to go and have a first look. Just go to the Cancer Directorate pages and there's 6 buttons with links to those helpful pages. So please do go there. It's got how to do a VA, how to get things approved, ordering processes. It's got a whole heap of information, annual leave policies, working from home policies. They're all linked to from those Connect pages. We're trying to make them a bit of a hub. So please do go and have a look and have a play. And if there's things that you think would be useful to have on there, let us know, email us and tell us, and we'll look at how we can do that and if we can do it. So yeah.
Thank you, Kevin. I think that's a good place actually to remind people in terms of approvals for things. So you'll all have no doubt been keeping an eye on the news over the last few weeks, and in terms of the NHS finances overall, it is an increasingly tightening position. So if you are wanting to spend money on something, order something through Oracle, taxi for a patient, recruiting to a post, getting bank replacements for people, there is a number of additional steps that we have to go through to get approvals now. So really just think about what you're asking for. Is it the right thing to do for patients? Make sure you've requested them on the right forum first. If it's something going through Oracle, we have to have approval on Oracle before we can have an invoice for something now. So if you are purchasing a service, something like that, and you get an invoice, normally we have to have approval on Oracle for it first. The same as if you are recruiting to a post or putting a post out for bank, again we have to have approval through our vacancy authorization, our VA process, and all of those details are on our Connect pages. So they obviously do take a little bit longer to get through and approved, so please think about them ahead of time if you can. Obviously, if it is an emergency and somebody's off sick and you need replacement, then there are processes in place. We can pick it up quickly, but things are going to just get a little bit tighter from a finance perspective, which is quite right. We should be really careful with the public money that we're spending. So just please think about what you're doing and making sure you've got the right approvals for things in place. Again, if you're stuck, if you haven't got a clue what I'm talking about and you want to know, please email our senior team inbox, and I'm very happy to update anyone. And if no one's got any other grotty questions for me, it will just leave me time to say thank you all very much. I hope that you all managed to get a little bit of time in the sunshine this week. It might be the only week of summer that we get, and then I can start the countdown to Christmas already. Sorry, everyone, I've said it. My favourite time of year. Thank you all very much, and hope you get a bit of a break over the summer, spend time with your families, and thank you for all you do, and see you next time.